In this episode, I wanted to do a presentation on interventional psychiatry, more broadly speaking. I just wrapped up a few episodes on ECT specifically, but I wanted to take a step back and tackle what is interventional psychiatry and give a broader overview of that before I get into more of some of the specific modalities. But before we get into interventional psychiatry, let's contrast that with conventional psychiatry. So conventional psychiatry includes, of course, psychotherapy. And there's a bunch of different flavors of psychotherapy: cognitive behavior therapy, psychodynamic therapy, interpersonal therapy, so on and so forth. And then, of course, there's our medications. We've got the conventional antidepressants like serotonin reuptake inhibitors, SNRIs, atypicals like bupropion and mirtazapine. We have mood stabilizers like lithium and lamotrigine. We've got anxiolytics, particularly the benzodiazepines. We have antipsychotics, we have stimulants, we have sedative hypnotics, and quite a few others. So basically, psychotherapy and medications is conventional psychiatry. What is interventional psychiatry? So interventional psychiatry is, there's no, I don't think, consensus definition, but I will propose one. And it is that interventional psychiatry is an emerging subfield of psychiatry that encompasses invasive medication delivery routes, such as intravenous ketamine infusions, which traditionally fall outside standard psychiatric practice, and medical procedures that aim to directly modulate neural circuits implicated in psychiatric disorders. So that's one definition. Some people might not include things like ketamine in interventional psychiatry because at the end of the day, it's still just medication. And we do have to admit that this term is a little grandiose. I mean, you think about interventional radiology or interventional cardiology, these are procedures where they're directly intervening on a pathological, plaque or something of that nature. We are still not that precise yet. So in my opinion, the term interventional psychiatry is a bit grandiose, at the worst, and at the best, it's very aspirational. But hopefully we'll fulfill the term. Hopefully we will have very precise lesion specific tools that will help us intervene directly on the pathological brain circuits, but we're not there yet. So to put this in a little bit more of a analogy, with something like interventional cardiology. So in interventional cardiology, like I said, you're basically doing you're threading catheters through veins and arteries to open up a plaque-filled blood vessel, or at least that's probably the major thing. You might be inserting a stent or doing an ablation, and et cetera, et cetera. So basically, the focus in interventional cardiology is on life-threatening or severe heart conditions, and in interventional psychiatry, the focus is on treatment-resistant or severe mental illness. In interventional cardiology, I went through some examples of that just now. In interventional psychiatry, some examples of that are ECT, TMS, ketamine infusions, deep brain stimulation or DBS, and vagal nerve stimulation or VNS. In interventional cardiology, generally, these are high acuity issues. So, acute myocardial infarcts, arrhythmias, valve stenoses. In interventional psychiatry, this is severe depression, mania, suicidality. In interventional cardiology, the setting is the cath lab or operating room. And in interventional psychiatry, this could be the clinic or hospital. In interventional cardiology, the goal is often immediate restoration of blood flow or rhythm. And in interventional psychiatry, often the goal is rapid symptom relief or addressing circuit dysfunction. So that is kind of how we stretch the analogy to make the term fit. So as I kind of already alluded to, there are a few established interventional psychiatry treatments, and then there are a few emerging treatments that we'll talk about. So the very established interventional psychiatry treatments at this point are electroconvulsive therapy, ECT, transcranial magnetic stimulation, and together we would call those neuromodulation modalities. And then there's ketamine, which can be delivered via different routes. There's the intravenous route, there's the intranasal route, there's intramuscular, and there's by mouth as well. You could potentially throw in vagal nerve stimulation as an established treatment because it has been FDA approved since I think 2002 or somewhere in the early 2000s. So it's been around a long time, but I would generally not include it as an established interventional psychiatry treatment because it's not something that is widely used at all. Basically, no insurance companies cover it. So it's, even though it's FDA cleared, you will not see it used unless you're at an academic center. So let's first go into neuromodulation modalities. And I wanted to start with a little bit of history. So the earliest use of electrotherapy was by ancient Greeks and Romans using the torpedo fish, also called electric rays. And basically, you could grab these fish and use them to shock people. And it was used for all sorts of things like headaches, gout, arthritis. It was even used and promoted by famous physicians you might recognize like Hippocrates and Galen. So this is the earliest records of some sort of neuromodulation technology being used. So this is, the idea of shocking people is not new at all. Then there was the Leyden jar. The Leyden jar, that's spelled Leyden. So this was first invented in the mid 1700s in Europe, and it's the earliest form of a capacitor. So it's a device that can store an electric charge and discharge that electric charge quickly. Similar to the ancient Greeks and Romans that we just talked about, Leyden jars started to be used therapeutically for a broad range of conditions, from muscle spasms to headaches and even mental health conditions. So, you would have these jars administered or used to administer electric shocks to people with various ailments. Getting into modern neuromodulation techniques, getting into transcranial magnetic stimulation or TMS. The first TMS device was developed by the bioengineer Dr. Anthony Barker in 1985 in the United Kingdom. And he basically developed a device that delivered brief electromagnetic pulses with a handheld stimulator. And you can find pictures online, but he could place this stimulator, the pulse generator, over the motor cortex and cause the subject's hand to move. So the physics of this is pretty well understood. Some of you may have an Apple Watch or a wireless toothbrush, and basically all those wireless charging devices use the principles of electromagnetic induction to charge. So basically, a moving magnetic field creates a current. And so by creating a rapidly changing magnetic field, electromagnetic field in a wire, we can induce a magnetic field and induce a current in the brain. Essentially how this works is you can basically just run a current through a loop of wire and turn it on and off really quickly, and that generates an electric current. And if the electric current is rapidly changing, that generates the changing magnetic field. So TMS first invented 1985. So TMS machines, they can generate a magnetic field of around 1.5 Tesla, which is actually similar to kind of the more inexpensive MRI devices in magnetic field strength, but they're much smaller. The magnetic field is much smaller. An MRI machine can, fill an entire room with its magnetic field, and the TMS device is much smaller, even though the magnetic field strength is actually fairly similar. And these magnetic pulses penetrate the skull. They induce electric currents in cortical neurons through electromagnetic induction. And I will reference Faraday's law. And what the interesting thing is, by doing this, we can actually both enhance cortical excitability, basically increase the activity of neurons, or reduce cortical excitability, essentially reduce the electrical activity of certain parts of the brain by changing the frequency of these pulses. So high frequency pulsing, greater than 10 hertz, can enhance cortical excitability, and low frequency pulses reduces cortical excitability. You can also change the shape of the electromagnetic field. So different coil shapes can focus the magnetic field on specific cortical regions to induce different clinical effects. You can have magnetic fields that are quite broad but penetrate deeper, or you could have magnetic fields that are quite focal but more superficial. And there is an inherent trade-off between focality and depth. So the deeper you want to get through the skull, the deeper you want to get into the brain, the broader the magnetic field will have to be. And if you want to target a very small area, the more superficial you'll be restricted. The pulses are brief and rapidly alternating. This prevents tissue heating and damage. We have to avoid ferromagnetic objects on or around the head or neck to avoid heating. And the main risk of TMS is inducing a seizure in susceptible individuals. So in 1985, as I mentioned, Dr. Barker discovered that we can activate brain cells using magnetic pulses. We can make people's muscles twitch, but it wasn't until later that we realized it could be useful for psychiatric disorders. It turns out around the same time in the 1980s and 90s, neuroimaging research was starting to blossom, where scientists could use brain scans to look at differences in brain activity in patients with psychiatric disorders compared to healthy control subjects. And there were some early studies using PET scans, which basically gives you a window into the activity of different parts of the brain by looking at the brain's metabolism of glucose over time. So what they found is if you look at patients with depression and you scan their brains, you basically create a movie of the activity of their brains, and you compare it to healthy controls without depression, you'll see that the depressed patients have significantly lower brain activity on average, especially on the left side of the brain, specifically the left dorsolateral prefrontal cortex. And so the idea was, okay, so these depressed patients have less activity in the left dorsolateral prefrontal cortex. So what if we try to rescue that by using TMS to boost the activity? Will that actually treat the depression? Is that hypoactivity in the left dorsolateral prefrontal cortex just a artifact, or is it actually potentially part of the causal explanation for the depression? So later studies, there's for example, a study from 2001. This is well before TMS was ever FDA approved, that showed that indeed by using TMS to stimulate the left dorsolateral prefrontal cortex in depressed patients, you could rescue the hypoactivity in that brain region, and that also correlated with improvement in depression. So there were a number of studies that were done in this vein, ultimately leading to TMS being FDA cleared for major depressive disorder, treatment-resistant depression specifically, in 2008. These days, there are many device manufacturers that produce TMS devices. There are at least 8 to 10 devices approved or cleared in the United States. Most of them for depression use a treatment course of about 20 minutes of stimulation Monday through Friday for 6 to 9 weeks. That's the kind of standard course. And there have been other indications for TMS besides depression. There's some evidence for, it's actually FDA approved for anxious depression, as it's called, for smoking cessation. And even in neurology, there's a lot of studies on this ongoing. So there's good evidence for use in neuropathic pain at this point and motor recovery after stroke. So TMS is really becoming a broad spectrum tool because you can target different brain regions. And of course, we expect that different conditions are going to have different brain regions involved. There's even a small handheld device that patients can administer themselves called the e-neuro device for migraines. And this is a single pulse TMS device. So I should back up and say that you'll see terms like RTMS or TMS used interchangeably. RTMS just means repetitive TMS, and that's because we're using a train of pulses like da 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 at a time. Whereas the single pulse TMS device for migraines literally just emits a single pulse. All right, so that's all I'll say about TMS at this point. I expect in the future I will have a whole episode or maybe a series on TMS specifically. Um, I'm going to move on to ECT, which I've already had a series on. But just to briefly review that, ECT is a psychiatric medical procedure where an electrical stimulus is used to induce a generalized seizure under general anesthesia and paralysis. And it's used for treatment-resistant depression, acute suicidality, bipolar mania, catatonia, and acute psychosis. The mechanism is unclear, but I will talk about some hypotheses for how it works in a bit. The main side effects include short-term memory loss, headaches, and confusion. And then there's rare longer-term cognitive side effects that are possible. But overall, the main medical risk is just the risk of general anesthesia. Anytime you go under general anesthesia, there are significant risks associated with that. The anesthesia equipment could fail. Someone could aspirate. Someone could have an arrhythmia because of one of the anesthetic agents induced, so on and so forth. So that's really the main medical risk of ECT is just the general anesthesia. ECT is considered the most effective treatment for treatment-resistant depression, and it's very effective for catatonia. So touching on how we think it might work. So there's basically 5 main hypotheses for how ECT works. The first that I'll talk about is the neurogenesis hypothesis. And this suggests that ECT works by promoting the growth of new neurons, particularly in the hippocampus, which supports mood regulation and cognitive function. So there's only a few areas in the brain where new neurons are actually born. The rest of the brain is basically post-mitotic. So the hippocampus is one of those regions, and evidence does suggest that ECT does induce a neurogenesis in the hippocampus, but whether that is the mechanism behind ECT's effectiveness is unclear. Then there's the neuroendocrine hypothesis, which suggests that ECT modulates the hypothalamic pituitary adrenal axis, the HPA axis, thereby reducing stress hormone dysregulation that's often associated with depression. There's the anticonvulsant hypothesis, which suggests that ECT induces enhanced inhibitory mechanisms within the brain, particularly in the frontal lobes, and that somehow helps with mood regulation. So we know that over a course of ECT, the seizure threshold tends to increase. So there is there does seem to be some kind of an anticonvulsant property to ECT that is cumulative over multiple treatments. But again, whether or not that is the causal factor or a causal factor in its clinical efficacy is unclear. Then there's the network hypothesis, which says that ECT works by reorganizing dysfunctional brain networks. That one is a little bit hand wavy because it's what does that mean exactly? That's sort of the least specific of these hypotheses. And then lastly, there's the monoamine hypothesis, which suggests that similar to medications like standard antidepressants, ECT enhances the release and receptor sensitivity of key neurotransmitters like serotonin, dopamine, and norepinephrine involved in mood regulation. So again, those are some of the mechanisms by which we have evidence that ECT actually does make those changes, but whether those are causal factors remains unknown. All right, so that's all I'll say about ECT for this context. Moving on to ketamine therapy, and this encompasses Esketamine or Spravato and IV ketamine. So ketamine is an NMDA receptor antagonist, and it was first used as an anesthetic agent and is still used as an anesthetic agent. And then it was later discovered that at low or sub-anesthetic doses, it can be a rapid-acting antidepressant. It's used for treatment-resistant depression, acute suicidality, and it's under investigation for a number of other psychiatric conditions. The mechanism is unclear. I mean, we know how it works at a molecular level, but how NMDA receptor antagonism results in improved depression is still unclear. We believe that it enhances synaptic plasticity and promotes neurogenesis, so there's definitely an overlap in how we think ECT works. So ketamine can be administered in a variety of ways: intravenously, intranasal, insufflation. Those are the most common ways, but you can also give it intramuscularly, sublingually, and there are also just pill formulations. It can often be effective within hours. So I've certainly seen this in my practice where patients with severe depression come in and, basically immediately after their infusion are feeling a whole lot better. And that can last for several days. But I've also seen cases where patients don't experience that rapid improvement, but they do ultimately get a significant clinical response or even remission after several weeks of repeated treatments. Common side effects include dissociation, dizziness, nausea, transient hypertension, and of course, there's the rare risk of misuse because it is also a street drug. So those are basically our established interventional psychiatry tools at this point. Now I'm going to move into some emerging treatments in interventional psychiatry. Vagus nerve stimulation, vagal nerve stimulators, VNS. So this involves delivering electrical impulses to the vagus nerve via a surgically implanted device. And we think this modulates brain regions implicated in mood and behavior, such as the locus ceruleus and the dorsal raphe nucleus and the limbic system. It is indicated for treatment-resistant depression and epilepsy. And so patients would need to have an outpatient surgical implantation of a pulse generator, which is connected to the left vagus nerve. And you will need to work with a psychiatrist who's familiar with this and trained on this to program the stimulation sessions. And you can, there's a variety of parameters that you can control. It has, in terms of efficacy, it has demonstrated some long-term improvements in depressive symptoms and treatment-resistant depression, but oftentimes the studies basically show that you don't tend to see much of an effect until like 3 months or even as far as 12 months after getting the stimulator implanted and turned on. Side effects are basically related to irritation of the vagus nerve. So this can include vocal hoarseness, throat discomfort, or coughing. And then rarely you can get bradycardia or even dyspnea. There is an external trigeminal nerve stimulator device that has been FDA cleared for ADHD. And then something I'm particularly excited about is low intensity focused ultrasound, or LIFU. And this involves using focal beams of ultrasound, focused beams of ultrasound, low intensity ultrasound that can penetrate through the skull and very deep into the brain and be used to stimulate parts of the brain. So basically, the mechanical pressure somehow modulates the neural activity, and the biophysics of that I am not too sure about yet. So I'll have to maybe do a more dedicated episode on that after I have learned more about it myself. But the advantages of it, similar to TMS, it's non-invasive, it's reversible. You can precisely target deep structures like the thalamus or amygdala, which you can't do with TMS. And then there's minimal off-target effects due to its focality. There's also high-intensity focused ultrasound I should briefly mention, and that can actually be used to ablate brain tissue. So that's basically a neurosurgery. All right, and then moving on, we have transcranial direct current stimulation, or TDCS, and cranial electrical stimulation. So both of these basically involve using low intensity electrical currents through the scalp. So it's kind of like ECT in a sense. You're putting electrodes on the head and passing a current through them, but these are very weak currents. Usually so low that they're not perceptible, or you might just have mild tingling. The data on these technologies is pretty mixed. Overall, there doesn't seem to be a lot of benefit, but these are very cheap, inexpensive devices. So if somebody can get them to work reliably, then that would be great from a cost of healthcare perspective. There's magnetic seizure therapy, which is basically ECT, but using a TMS device. And the advantage, or the purported advantage of that, is that you can trigger the seizure where you want to trigger it in a more focal area. And again, try to avoid those hippocampal memory structures, the temporal lobes, so that you have fewer memory side effects. So that is in active investigation. There's stellate ganglion block. So this involves an anesthetic injection into the stellate ganglion, which reduces sympathetic nervous system activity, which can potentially reset overactive neural circuits linked to PTSD and anxiety. So stellate ganglion block, there was some studies in the VA specifically for PTSD that was, looked pretty promising, but this is definitely not an established treatment. It is an outpatient usually ultrasound guided or fluoroscopy guided procedure to inject the anesthetic agent into the stellate ganglion, which is one of the sympathetic ganglia. And then often it can lead to rapid symptom relief with minimal invasiveness, and the effects can last weeks to months, even with a single injection. Side effects include temporary Horner syndrome, which is, let me see if I remember, meiosis, ptosis, and anhidrosis, right? Hoarseness or mild pain at the injection site. There's deep brain stimulation, which involves implanting an electrical stimulator inside of the brain, and in specific brain regions that are known to modulate neural circuits involved in the condition that it's being used for. So it is currently being investigated for treatment-resistant OCD and depression. Some of the brain regions that are targeted are the subcallosal cingulate for depression, the lateral habenula for depression, or the ventral capsule for OCD. And this involves stereotactic electrode placement connected to a chest-implanted pulse generator. And then, similar to VNS, you've got to adjust the device parameters. There have been only case series or case studies on these, given the huge, resources needed to do a neurosurgery. But this is also something that is only investigational at this point. The risks are substantial. Anytime you're doing neurosurgery, there's obviously the risk of substantial risks, infection, hemorrhage, frank brain damage. There is excitement around closed loop PBS, where you're both recording. You have an implanted recording electrode and a stimulus electrode, and the stimulus electrode is guided by the recording electrode. And the last thing I'm going to talk about is ablative psychiatric neurosurgery. So this involves the targeted destruction of specific brain regions to modulate dysfunctional neural circuits in severe treatment-resistant psychiatric conditions. So some of the study techniques involve an anterior cingulotomy, so lesioning the anterior cingulate cortex, and this can be used for OCD and depression. There's capsulotomy, which targets the anterior limb of the internal capsule for severe OCD. There's the subcaudate tractotomy, which disrupts the limbic pathways for mood disorders. So right now it's, potentially indicated for severe OCD, depression, and occasionally chronic pain syndromes. And of course, again, with brain surgery, there are substantial risks, although some of this can be done with thermal capsulotomy, gamma knife, or even high-focused ultrasound in some cases. All right, so hopefully some of that was helpful, just as a broad overview of both established interventional psychiatry and maybe some of the technologies that will become established in interventional psychiatry. Feel free to email me any questions or comments at Brandon, BRANDON, at brandonbrownmd.com. Thanks.